Hello, everybody. Welcome to the March Gravity Implementation Affinity Group. We're going to be getting started very, very shortly. We're just going to let people roll in over the course of the next few minutes, and we'll get started a few minutes after the top of the hour. Again, welcome, everybody. We are going to start ever so shortly, probably one more minute just to let folks roll in. We have a lot to address today, and we're really looking forward to covering our topic and with our friend and member perspectives laid to bear. Okay, given that we have a fair bit of introductions, of initial slides, I'm going to start going. My name is Sarah DeSilvi. I have a few roles here at Gravity. One of them is the Director of Terminology, and then I also help with the Affinity workstream. We are so honored to have you here. The first thing on the landing page is discussing the Gravity Project antitrust practices that we abide by as part of being in relationship with HL7. So Gravity Project participants have the responsibility to comply fully with federal and state antitrust laws. Individuals speaking or providing written communications shall refrain from any discussion which may provide the basis for an inference that they have agreed to take any action related to prices, services, production, and allocation of markets, or any other matter having a market effect. Participants shall not discuss their pricing or others' pricing or any term that might affect pricing or fees, such as cost, discounts, terms of sales, or profit margins. Adherence to these guidelines involves not only avoidance of antitrust violations, but avoidance of behavior that might be so construed. Thank you so much. And now into the meat of our show. Next slide. We presented this first last meeting, but we wanted to just level set again. The Gravity Implementation Affinity Group has a really unique purpose within the Gravity workstream family in honor of the significant advancement implementation and steps beyond the limited nature of pilots. In 2024, we're simplifying and expanding our names of this place and what we do here. So the work stream has been renamed the Gravity Implementation Workstream. This meeting, where we are today, has been renamed the Gravity Implementation Affinity Group. The mission across the workstream is widespread adoption and use of Gravity deliverables and fostering an implementer-driven community geared toward continuous improvement. The Affinity Group is an open public forum. We are incredibly grateful that Gravity member Civitas Networks for Health will continue to administratively support the Affinity Group with in-kind efforts through 2024. And we have a really important thing to note. So given the operational, we're switching from Civitas spaces into Gravity spaces just for continuity, and so you can find these meetings on the HL7 calendar. Given the operational transition, though, for the Affinity Group calls, participants will need to register for April's meeting and the preceding calls through a new Zoom link that will get sent out via the follow-up email. So moving from the Civitas registration from 2023, and thank you so much for gracefully carrying us over the first quarter of 2024. into Gravity registration and Gravity signups and availability on the HL7 conference call calendar. So again, in follow up to this meeting, there will be an email that will have a link for registration. And so you will have to register for the series anew. And then it will be available again on the HL7 calendar via its self-service method. So thank you so much for your patience as we transition. And thank you so much for Civitas for being a critical member and supporter of this work. And Demery will be dropping details on all above in the chat as we go forward. Next slide. Oh, it's nice to see so many friends in the chat. Just general housekeeping. Thanks you for joining Gravity Implementation Affinity Group meeting. The Zoom is always recorded. Recording will be available on the Confluence page. We ask that you mute yourself when you're not actively speaking, but there is going to be a robust option for conversation at the end of the meeting. Please use your raise hand function to chime in with questions or comments, or use your chat to share. Share video if you're able, but there's no pressure to do so. And if you have any technical difficulties, please contact Demery Henderson, d.henderson@civitasforhealth.org. She is the amazing coordinator holding the workstream together. And those of you who've been involved in Gravity Project in the past or from previous years should recognize her. She's been around for a while. We were just commenting on that. Grateful for her continuity on this work. Next slide. We have a great agenda. So what we did not state on the Affinity Group renaming and workstream renaming is really trying to center members in our implementation conversations for 2024. We have so many wonderful members in the Gravity ecosystem. And so when there's critical topics on education that relate to implementation, we're really trying to bring in member voices. So today's agenda focuses again on a critical topic. We hear from implementers who want to know more about the calendar year 24 social needs HCPC terms and how Gravity terminology aligns and supports those terms. In honor of that, we're going to be centering our dear friend, Tim McNeil, from the Partnership to Align Social Care, supported by our member organization, the partnership, who is June Simmons and Tim McNeil co-chair the Partnership to Align Social Care, and we'll hear more about that in a little bit as Tim gets into his presentation. I am then going to go into the Gravity support of those calendar year 24 HCPC terms. So Tim's going to start with the overall the perspective of the HCPCs themselves and the terms of implementation, and then we'll going into Gravity terminology support. An open discussion will follow. You all are welcome to ask questions of anyone at that time, and then we'll close out the meeting and do next steps. Next slide. Just as a grounding, if any of you are new, the Gravity Project is a collaborative initiative with a goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. We are an HL7 FHIR accelerator. Next slide. I mentioned our amazing members. So Gravity has a lot of wonderful ongoing members, including lots of federal partners. We also have a fair bit of new members. On the members, we have members who are supporting financially and also critical designated members representing critical social care voices. One of those designated members is the Partners in Care Foundation, who collaborates in the Partnership to Align Social Care. So again, that is that member and implementer connection. And thank you to all of our members for supporting the work of Gravity. If you want to become a member and become part of our governance and leadership structure and strategy and planning for what's next, you can see that link in the bottom of the slide, and it'll be dropped into the chat as well. Next slide. All right, so now I have the honor of transitioning the first part of the conversation to the amazing Tim McNeil. A leader in so many ways, leader in implementation specifically. He's a really amazing voice in the national ecosystem. So Tim, thank you so much for being here to represent the work of the partnership, and we are honored to hear you out for the next 20 minutes or so. Tim?
Great, thank you so much. It's a pleasure to be here. And so as Sarah said, that I am the co-chair for the Partnership to Align Social Care, which was really organized to bring together thought leaders from multiple sectors to include health plans, health systems, CBOs, and national organizations to really think about how to sustain and drive interventions to address health-related social needs through the use of leveraging the power of community care hubs. So today, I'm going to be really focusing on the new rule changes that CMS published in the calendar year 2024 physician fee schedule, specifically creating or discussing the creation of a new benefit or new set of benefits called community health integration, and then principal illness navigation and principal illness navigation peer support. Next slide. And so as a precursor, there is a new benefit called an SDOH risk assessment. And this is all of these services I'm going to talk about are new Medicare Part B benefits, which means they apply to all Medicare beneficiaries that are in fee-for-service or original Medicare. But because these benefits are a Part B benefit, it also applies to Medicare Advantage and special needs plans, but they have a little bit of a delayed implementation, but all Medicare Advantage and special needs plans. So there's a broad population that are eligible for these services, and these services began on January 1. So the first part is the social determinants of health risk assessment. Next slide. And so this is the Part B benefit that pays for the labor to conduct a health-related social needs screen. It can be performed once every 6 months per beneficiary, and it is an add-on service as part of an established health encounter. And the types of established health encounters include like an E&M visit or evaluation and management visit, which is a general medical visit, a psychiatric evaluation or health behavior and assessment intervention, and annual wellness visits. It is an established benefit that is done by an eligible healthcare provider, either being a physician or non-physician practitioner, such as a nurse practitioner, physician assistant, as well as a clinical psychologist. And because of the tie-in to the health behavior and assessment intervention, where CMS expanded the rules on that benefit that allow clinical social workers to provide the service, it also opens a door for clinical social workers to document and be reimbursed for completing a social determinants of health risk assessment. It does require the use of an evidence-based tool. The two tools that were given as a reference is the CMS Accountable Health Communities tool and the Prepare tool. Next slide. So when one of the eligible providers has an established health encounter with a beneficiary, they can, in addition to that visit, they can complete this social determinants of health risk assessment. There's a HCPCS that's assigned, the G0136, and the rate there is $18.66. For federally qualified health centers and rural health centers, it is included in the PPS rate, so they don't get an additional reimbursement, but they are encouraged to do these services. One thing that a lot of times I get asked about, what's the difference between a screen and an assessment? For the assessment part, not only are they completing the screen, they're documenting the outcomes of the screen, updating the problem list in the electronic medical record, and with the intent of establishing an intervention or treatment plan to address the identified needs. The totality of those activities is the risk assessment, where the screening is a component of the risk assessment, and the benefit reimbursement covers the full assessment. Next slide. So now that there's a pathway for reimbursement for providers conducting the risk assessment or SDOH assessment, then separate from that, CMS created a pathway for reimbursement for addressing the identified needs. That benefit is called community health integration. Next slide. So this is a Part B benefit for the labor that is spent addressing identified needs. The intention of this benefit is that a provider, an eligible provider, will utilize auxiliary personnel, and those personnel will work with beneficiaries to address identified social needs. The needs have to have a direct impact on the ability of the provider to treat or diagnose the condition. So CMS was very clear that you can't address social needs just for the purposes of addressing social needs, but there has to be a direct tie to a clinical outcome that's being prevented or hampered by the social need, and that must be in the documentation. And when that occurs, then the provider eligible provider can have auxiliary personnel, which could be community health workers, promoters, health coaches, and there was the direct information in the rules that said providers can contract with community-based organizations to provide the workforce or the labor to address the social needs. So the providers don't have to, and clinical practice don't have to figure out how they staff up to provide these services, but they can contract with. The services will occur under general supervision guidelines, which essentially means that the person, let's use the example of a community health worker. A clinical provider contracts with a community-based organization. That community-based organization deploys community health workers to address social needs that were identified during a clinical encounter. When they are, the community health workers will be working using a generalized plan of care, and then they will address the needs in the community, document the outcomes and interventions, and then exchange that information back with the provider that is providing the general supervision. When that occurs, then all of the time that is spent addressing the social needs is reimbursable. And the time must highlight that it is time working on behalf of the beneficiary to address identified social needs that are listed in the clinical record. So that time doesn't only include time that's spent face-to-face working with the beneficiary, but time working on behalf. So I often give the example, time spent addressing housing insecurity. Oftentimes that's time working with landlords, identifying resources, contacting the continuum of care, identifying if there's available vouchers that the person, housing vouchers that the person can apply for. A lot of that time is not time spent face-to-face with the beneficiary, but time spent working on their behalf. And all of that time per calendar month can be aggregated together for one sum total that is then billed based on time. And then I'll go into a little more detail about how the time allocation is defined for reimbursement. Next slide. So these services, I've mentioned that they must be, they can be rendered by auxiliary personnel that are working under that general supervision. Oftentimes I get questions about specific education requirements or licensure requirements for the auxiliary personnel. There are no definitive specific license requirements. However, the persons must have applicable training that is documented that makes them eligible to provide the services. And they, I mean, the auxiliary personnel. And if the state that they're practicing in has a defined scope of practice based on the work that they're performing, then you have to adhere to the state. So an example is if I'm working in a state and I am defined as a community health worker and I'm working with a FQHC as a community health worker. If that state has a certification requirement for community health workers, then I can't operate as a community health worker for these codes unless I meet the state level requirements. So CMS is deferring to the state scope of practice requirements that are defined based on the position that the person is holding that is providing the service to address the social needs. But there is not a limitation that it can only be community health workers. So CMS gave broad guidance that it can include, the auxiliary personnel can include community health workers, health coaches, navigators, even social workers, nurses, and medical assistants, as long as they adhere to the general supervision guidelines and they have applicable training. Next slide. This is the broad list of services that are incorporated as part of community health integration, and I'll highlight a few of them. Facilitating access to community-based social services, that's an obvious, but some that may not be as obvious. Things such as facilitating behavior change and health education, coordination of care transitions, particularly when a social need impacts a transition, like from a hospital setting to community. So if a person has a long history of being unhoused and they're trying to manage their diabetes and they're moving back and forth through the shelter system, then obviously their housing situation has an impact on the ability to develop a safe discharge. And now there's a payment pathway using community health integration to facilitate that transition back to community. Next slide. These are the HCPCS codes for each of these services. CMS has created HCPCS codes. And then that is critically important, because when CMS created a HCPCS code, not only is there a clear pathway for reimbursement under the Medicare, original Medicare, Medicare Advantage, and special needs plans, but these HCPCS codes become part of the National HCPCS Code Registry. So any health plan has an open door to adopt the same HCPCS codes for utilization of services. So the way that these codes are structured for reimbursement is that there's a minimum base of 60 minutes. And that's the first code, G0019. When that same example, a nurse practitioner at an FQHC identifies that there's food insecurity, assigns a community health worker to address that food insecurity, because there's a direct interaction on that ability of the nurse practitioner to manage diabetes because of the food insecurity. The sum total of time spent addressing all of the person's social needs is aggregated each calendar month and billed. The base of 60 minutes is the minimum threshold. So that first 60 minutes, we build the G0019. And every 30 minutes after the first 60 minutes, we bill another unit of G0022, and you see the reimbursement. So if we did 2 hours of time addressing social needs for a beneficiary during a calendar month, let's say that we're now at the end of March, and we spent 2 hours addressing the needs for Miss Jones, we would bill 1 unit of G0019 for $79.24, and then 2 units of G0022 to make up the total of 2 hours spent. The rates listed are the national rates, so there is a slight variation based on your geographic location and your Medicare administrative contractor, but that's the national rates. You see at the bottom, there is a code for FQHCs and rural health centers. For them, that is just one code, and that's G0511. That same example of 2 hours for an FQHC, for the first 60 minutes, I would bill 1 unit of G0511. For the 2 units of the add-on for the second hour, I would bill 2 units of G0511. So for 2 hours, I would build 3 units of G0511 if I was an FQHC, and I would receive 3 times $71.70. It's important to note for our FQHC and rural health center friends that the rates and reimbursement is not part of your PPS rate. So you would receive your PPS payment and separately would receive payment for delivering community health integration services. Next slide. Separate from the community health integration that is singly focused on payment for addressing social needs that were identified that have a direct impact on the ability to treat and diagnose a condition. Separate from that is principal illness navigation services. Next slide. For principal illness navigation services, this is a Part B benefit with a new set of HCPCS codes to provide navigation and case management services for beneficiaries that have a serious high-risk condition that's expected to last at least 3 months. And that condition places that person at significant risk of hospitalization or death. Next slide. There are some conditions that were given as a reference that could be considered as eligible services for principal illness navigation. However, there is not an exhaustive list. It is really the discretion of the provider to determine if the person meets the threshold of having a serious high-risk condition that has the potential for having poor outcomes. Some of the conditions that were listed as an example include diabetes, dementia, heart failure, as well as serious mental illness and substance use disorders. And the difference between community health integration and principal illness navigation, the eligibility factor for community health integration must be the social need, and that social need must be documented. For principal illness navigation, a person who has a serious high-risk condition, regardless if they have a social need or not, the condition makes them eligible, not a social need. But the same kind of rules apply. Auxiliary personnel can provide the service. Types of auxiliary personnel include patient navigators, health coaches, social workers. They would operate under general supervision. There would be a plan of care, and per general supervision requirements, there would be this interaction with the billing provider, giving them regular updates on the activities that were being performed. An example here would be a person with advanced dementia, and the family needs to make decisions about how best to care for their loved one with dementia, and they're really lost in the system trying to figure that out. The provider could assign a navigator to work with the family, and they can identify, whether or not this person could apply for a state waiver, or does their family resources and what types of resources could support that person in the home. Or maybe they've gotten to the point where they're unable to manage them in the home, and they have to start thinking about an institutional setting and what's the best institutional setting that is most appropriate. Now, the navigator could provide time helping the family to make those decisions, and then all of the time spent supporting the family would be billed under principal illness navigation. Next slide. Here's a list of the principal illness navigation services, and I'll highlight some of them here. The obvious is healthcare access and system navigation, but other things, facilitating access to social services, see that here, health education, leveraging their knowledge and history and to support the family, and just providing social and emotional support. And all of the time spent is now reimbursable per calendar month per beneficiary. Next slide. The codes are listed. These are, again, the HCPCS codes, and the same formula applies. Each calendar month, the totality of time is aggregated together to determine what is billed. The first 60 minutes, there's the base code, and that would be billed as G0023. And for every additional 30 minutes, with no cap and no limit per calendar month, you bill another unit. And so I gave the example of 2 hours spent, but you could easily see for families that are really struggling to find a solution for their loved one, the navigator could spend 5 hours and still not address all the needs in the calendar month. Well, as long as the services are necessary, documented, and part of the plan of care, then I would bill for the full 5 hours that were spent. And it's time working on behalf of the beneficiary, with the first 60 minutes being billed in every unit thereafter. And again, for FQHCs and rural health centers, for each eligible unit, they would bill another G0511. And then before I go into the next slide, just highlighting again that providers can contract with community-based organizations to deliver these services. And when I've been working quite a bit with integrated health systems, where there may be a hospital that doesn't bill Part B, but owns a clinical practice, or has a transition clinic or a heart failure clinic or resident clinic, which then becomes the base for these services. And then they're contracting with community-based organizations that extend the labor beyond the clinic into the community, where they're doing home visits and other services. And that entire continuum is reimbursed. And then lastly, these codes, community health integration and principal illness navigation, allow for concurrent billing. Where under concurrent billing, a provider that is providing, let's say, chronic care management services and transitional care management, it allows for all to be reimbursed for the same beneficiary during the same month, as long as it's clearly documented and the time spent is not double counted. Next slide. Then the last one is principal illness navigation peer support. And this is very similar to principal illness navigation, but it's limited to behavioral health conditions with a focus being peer support specialists providing this service. Next slide. So these services are limited to persons who have a behavioral health or substance use disorder where they're matched with a peer support specialist. That peer support specialist must have applicable training per state requirements. If they're not state requirements for peer support specialists in the state where services are rendered, then they must have, meet the training requirements that are defined by SAMHSA. General supervision requirements apply, and providers can contract with community-based organizations. I've neglected to say the eligible for providers for principal illness navigation and principal illness navigation peer support. The provider that's rendering the general supervision does also include clinical psychologists. So a behavioral health practice or a certified behavioral health FQHC that has clinical psychologists, the clinical psychologist can provide the general supervision and also bill for these services and have auxiliary personnel such as peer support specialists implement the service. Next slide. So the difference here for principal illness navigation peer support and principal illness navigation is that these services do not have the case management component because peer support specialists in their scope of practice, it doesn't include case management. So it's more the peer support component that is reimbursable under the principal illness navigation peer support. And again, this is limited to persons with behavioral health conditions. Next slide. So there was a question in the chat. I don't know how oh, sorry. I was going to jump on it. Sarah caught it. So the in the list of reimbursement, the same structure applies where there's a base of 60 minutes, and then for every 30 minutes thereafter, you could be addressing those services. And the way these could come together, when I mentioned the concurrent billing, I'll give you an example. So a person, again, had a recent admission to the hospital with a diagnosis of diabetes and also has food and housing insecurity, then gets linked to a resident clinic who then does a transition post-discharge visit. They identify that the person has food insecurity, so they need community health integration services. But maybe that person also has a comorbid behavioral health condition and needs principal illness navigation peer support services. So, and under this scenario, that person, we could bill for the transitional care management visit that's done post-discharge, community health integration services to address the food insecurity, and separately the peer support services to address the behavioral health condition, as long as the time is not double counted and is clearly documented and is part of a plan of care. And so because the allowance of concurrent billing, it also allows members of the clinical team, let's say in a traditional clinic setting, that time being reimbursed, and as they're handing off to community partners to extend into community, all of those services are reimbursed, and it's a total aggregate of time of all time spent addressing the need, not just one singular person. So if there's 3 persons on the care team that's all working to service Mrs. Jones, we're aggregating all of their time to determine what the bill amount is, as long as the time is not double counted. And just the example of double counting would be, let's say there's 3 persons on the team, and we have a meeting together to determine how to get this person a housing voucher. And we spent 1 hour as a group. I can't say that we billed 3 hours of time because we collectively worked together and spent 1 hour. That would be double counting if we did 3 hours. Next slide. And so again, the Partnership to Align Social Care, more information about the Partnership to Align Social Care is there, and look forward to the question and answer period.
Tim, you are amazing. Thank you so much for being expert in things that are totally mind-boggling to me. And I wanted your time question so directly relates to Dear Tom Page's question. You were just talking about time. So that's a very good question to start with. And then we also had another question up above regarding social workers. So if you want to answer Tom Page's question, and then we'll go back up to the top.
So Tom, recommendation on how to document the time spent providing service. Yes, excellent question. So what has to happen at every encounter, working on behalf of the beneficiary, the auxiliary personnel, I'll use the example of community health worker, should document the start time and the stop time and what the total time for that encounter is. And that should be in every clinical note. So there are a lot of systems out there that were built for chronic care management that have all kind of electronic stopwatches and all that. That's great, but you don't have to have a tool that's super robust. I know groups that are doing this now, and they are managing it with a spreadsheet where they, at each encounter, they put a start time, stop time, and it automatically totals the time. And that gets also captured in the note.
Tom, was that helpful? I hope it was. And then we also had a question up above from Joshua Collier. Mr. McNeil, when you say so, is this regarding social risk assessment? When you say social worker completing the assessment, do you mean social care workers, generally including community health workers, or are you referring to licensed social workers?
So that when I was talking about that part, it was for the social determinant of health risk assessment, which is
Correct.
exactly what CMS calls it. And the expectation for the social determinant of health risk assessment is that the provider, the clinical provider, the qualified provider does that. If auxiliary personnel do a subsequent screen, that's the difference between the screen and assessment. If they do a subsequent screen for, and this nomenclature is for CMS, they do a subsequent screen, that time doing the screen is billed as community health integration services. It's not billed as part of the social determinant of health risk assessment. And when I talked about social workers being eligible to do the social determinant of health risk assessment, it's a clinical social worker, because that social determinant of health risk benefit is for licensed personnel.
Any other questions?
Thank you so much.
We're going to have more time at the end for questions. Any other questions before we move on to how gravity terminology and approaches can support this? Hi, Matt.
Hi. It's very good to be here. Thank you so much for your presentation, Timothy. And I'm afraid this is not a question specifically about gravity, but is there any, I mean, since social care providers are providing assessments to address social needs, but may not have the clinical licensing, is there any kind of discussion at, when about ways that they might be reimbursed even if they don't have the licensing or without the clinical oversight of licensed personnel? Maybe I misunderstood part of it.
So there has to be this integration with an eligible provider in order to build any of these codes. So you absolutely have to have that connection, but
okay,
there is a pathway. So there's a social determinant of health risk assessment, which is roughly $18 that can be provided once every 6 months. But the community health integration services, there on that slide, if you go back to that slide, there's a list of services that are eligible. In that list of services, assessment and planning are eligible services. So that means that a non-licensed person, when they conduct a screen, their time is captured in the reimbursement for community health integration, but not part of the social determinant of health risk assessment, but it's still covered. But there does have to be this connection with an eligible billing provider.
Great, thanks.
Any other questions for Tim?
Yeah. Hi, this is Tom. I'm sorry, I don't know how to do the raise hand icon. Can you talk a little bit about what the requirements are for coordination between the initiating provider and the community health worker who's doing the navigation services or the SDOH services?
Excellent question. Yes. So first, there has to be documentation in the EMR that identifies the social need. That social need should be in the problem list. And in the plan of care, it should speak to the interaction between the social need and the health outcome we're trying to achieve, to show that connection. Then based on that, then there should be a plan to address those social needs. The community health worker or other auxiliary personnel operating under general supervision need to, one, know what are the items that are listed in the problem list that impact health outcomes. They recommend Z coding, but it's not mandated. Separate from that, the community health worker needs to be documenting the services that they're doing and providing access to that documentation to the billing provider on a regular basis. They say regular basis, there's no specific time point. I've heard people say it has to be weekly, but I went back and read the rules over and over again. They just say regularly, there is no specific time point, but I suggest, because the services are billed per calendar month, at a minimum, there needs to be at least virtual interaction with the provider once a month, where there's documentation that is sent to the billing provider with a summary of activities and the outcome of those activities, a minimum of once a month or more frequently, and a process to escalate issues that have clinical importance or there's concerns about.
So that could be done, say, on a secure server, communication between the community health worker and provider with a secure email response to the community health worker as to what they should do next.
Yeah, you're absolutely right. So I have a network in North Carolina that's implementing this now, and that's exactly what they have. They've set up a secure messaging system, and through that secure messaging system, the community health workers provide a report every 2 weeks on activities, as well as they can send high alert messages if there's immediate concerns that they've identified in the community that need to be addressed. So that regular communication, it can occur through secure messaging. It doesn't have to be an elaborate IT system with, real-time integration. None of that's required. It's possible, but it's not required.
Thank you. This answers so many questions for folks we've been working with. Hugely helpful. Thank you so much.
Sure.
Evelyn Gallego has a question near and dear to my own heart. I promise I didn't plant my dear friend. She has a question regarding USCDI. I'm going to, of course, go into how Gravity can support this with USCDI, but in the specification of the regs, is there a requirement for documenting using USCDI data elements?
So there is not. However, I've already started talking with integrated health systems, and their approach to this is they want to use structured data elements so they can, one, assess the impact of these interventions, but also look to see how these services impact future utilization and clinical outcomes. So if the data that's being documented in the plan is not structured, then the ability to pull the reports is limited. And so to the extent possible, we can encourage providers and give them a roadmap to do that, and then also help them understand the benefits where they can define the impact. We'll get more structured use of that, but the rules don't require it.
And Tim, you couldn't have set us up better. Evelyn was a plant, and then Tim, you gave the answer. And so that's an excellent segue into the next section. Before we go into, so Rob, this is literally the next section of the presentation, is talking about aligned structured data elements within Gravity USCDI value sets to support the HCPC terms that Tim just mentioned. And we only are focusing on the social needs relevant ones because this is a Gravity call, but we thought that might be helpful, and I'm glad you all think it is. So first of all, before we move on, I really want to thank Tim. I want to thank the Partnership to Align Social Care. I want to thank our members, partners in care, for being such a critical part of Gravity and just the ongoing collaboration. I wanted to also state one of the things Gravity has stated from a long time, from our origin, is our strategic vision right now and has longstanding is supporting social care entities in service delivery and the labor that they do. These codes are a significant advancement toward that, especially the CHI terms. Very, very excited about how these these terms will be able to be employed to support social care service delivery. So now I'm going to go into how gravity resources and terminology can map in and braid and support those HCPC terms with standard elements, really trying to kind of like the golden like the golden ticket, right? You have the HCPC offering the reimbursement, and you have the discrete terminology available in gravity to take you a little bit deeper and look towards outcomes. Next slide. So the objectives of this next section are convey how gravity implementation resources can assist with calendar year 24 social needs, HCPC codes, practice and documentation, and this includes instrument selection, social risk documentation with those IC10CM and SNOMED CT codes, right? So you have the Z codes that are suggested and the SNOMED CT codes for that problem list. And talk about how to support community health integration activity documentation with gravity SNOMED CT terms. So everything on that list, on that table, we kind of break out into gravity terminology, which aligns with quality and regulatory drivers, really trying to, again, give entities the discrete documentation that they need. Feel free to raise your hand as we go forward. I really want to make sure everybody understands as we go along. I didn't throw Tim to the fishes there, but you're welcome to stop me. And, for those of you who've ever been on a gravity call, I love being interrupted, so you can bring it. I know, and Tim just did the best. Tim is amazing. Tim just did the best job. All right, so with the objectives in hand, we're now going to go in and Tim, feel free to pepper in your brilliant perspective on implementation as we go forward. Next slide. Just a general grounding again. So there's a lot of terms we're going to be using over the course of the next slides. This is the gravity lexicon that we use as we reference, and it's important because we'll be talking about a few different types of things. So we have health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. We have social terms of health, which are divided into different both protective and negative forces. So protective factors being the characteristics or strengths of individuals, families, communities, or societies that act to mitigate risk and promote positive well-being and healthy development. You see elements of fostering protective factors in that CHI activity list. And so we want to make sure that we highlight that. Goals also come into play here as well. And then we have our negative forces of social risks and social needs. So this is what's important. We consider the work we have to do today. Next slide. Everything we'll be talking about here today is terminology. There are technical implications to everything, of course, as well, because all of the activities we're talking about in practice in CHI and the terminology that we're using have balancing resources within our implementation guide. But this is just the terminology curation process that we follow in Gravity to create terms that really are trying to blend and support the activities of social care across the healthcare and social services ecosystem. Next slide. This is an example of the terminology that we come up with in that consensus process. So terminology to support discrete documentation of screening and assessment, and we'll talk more about that shortly. Terminology to support documentation of diagnoses. So we're talking about those IC10CM codes and SNOMED CT codes, right? And food insecurity is just one example of the 19 domains we've addressed so far. Evelyn was bringing in care planning. So we have care planning terminology as well, with every single domain having goal-oriented terminology that also can represent protective factors or positive statements for different patients. For instance, in this instance, food security is the goal from a food insecure state. For a different patient, food security might be an asset if they are living rurally and are transportation insecure, but are able to grow their own food. And then we have a host of interventions. And again, a lot of the interventions we'll be talking about shortly, because with activities of CHI, the themes of them are braided into our intervention terms, which again align with USCDI. It's almost like it was designed that way. Next slide. I just wanted to state this here because part of what Tim is speaking of health systems and wanting to make sure that they're aligning with standards is because there's a lot of drivers in the ecosystem that are asking them to, right? Whether it be a desire to map interventions and outcomes and track the the heft of what we're doing, or whether it's US HIT data standards saying that you need to align with USCDI V2 by 2026, which is certified health records are bound to a certain status of USCDI for certified status. Also, our screening and intervention value sets that are for gravity, which are USCDI aligned, are the base of many current and emerging quality measures in CMS policies and regulations. So if I were an entity and I was wanting to integrate CHI, the HCPCS term is going to be certainly within gravity value sets in our update in June, but all those screening questions and answers and there's intervention terms that are already gravity aligned can support discrete documentation and align with NCQA, CMS, and other quality and regulatory drivers. Linnell?
Yeah, just a quick question, maybe a little slightly off base, but now that OMB announced, I guess today, that the race and ethnicity codes are going to be changed effective today and required in 3 years, is that a regulatory driver that would need to appear on this page, or is it unrelated and should be somewhere else?
It's not specifically referencing gravity materials, so it's not on this page, but it's certainly significant and important for evaluating inequities and outcomes, and so it's definitely relevant. Is that a good answer?
Oh, that's a perfect answer, because I looked at
Okay.
it and saying, I'm not sure if it fits on this page,
Yeah,
but
it's not just
sure.
pointing to gravity curated
Yeah.
stuff, but it's we talk about the critical nature of understanding demographics for analyzing outcomes all the time, right? That data would be very critical for the kind of terminology, for the kind of evaluation that Tim talked about health systems wanting to do. So next slide. Okay, so we're just level setting now. We're about to getting into the nitty gritty. Gravity has a host of resources to support implementation that we were honored to work actually directly with our friends at Civitas on over the course of 2023. Much of these resources will be talked about over the next slides. There are resources for like general library of information, value sets, screening instruments, the implementation guide, coding guidance. We're going to be talking about those shortly. Again, they're all available on everything we talk about in the next slides is available on the Gravity Confluence. Next slide. So on the implementation resources, within the implementation resources and Confluence are the following things, and we're going to be talking about them again as we go forward. There is, in the general resources library for implementation, there is a brief on CMS guidance for the new HCPCS terms. We have that uploaded there. There are resources for coding social risk and care settings with guidance for coding IC10CM from the AHC tool that's recommended in the guidance and Prepare. So both of those core tools, there's IC10CM coding guidance. There is guidance on looking at all the approved gravity screening instruments that apply, and we'll talk about why that's relevant for this conversation shortly. And then there's also all of the gravity terminology value sets, and we'll talk about how they apply as well. So all of this information is available on the Gravity Confluence for use when it comes to understanding how to implement these new HCPCS terms and align them with discrete gravity terminology, whether it be through direct care provision or care planning or care navigation. It's all going to hopefully come together in a nice little Venn diagram shortly. Next slide. Next slide. Okay, so this is on, I called it wrong. It's the SDOH risk assessment, Tim, and my apologies, the terminologist named it wrong. What I wanted to do from a gravity perspective is dive a little bit deeper into the recommendations for screening instruments. When they say evidence-based screening instruments in the regulation, there's a way that gravity can support you in selecting instruments. We wanted to go into that next slide. So again, throughout these slides, I call it social risk assessment. It's SDOH risk assessment. Know that I messed that up. So CMS guidance for the social risk assessment HCPCS detail the domains that should be addressed in this activity. And Tim, correct me if I'm wrong, if there's anything that I'm saying he's such an expert in this, but they are as detailed in the reg: food insecurity, housing insecurity, transportation needs, and utility difficulties. I just want to note, for the sake of reference, these align with the current IQR measure, except for the fact that interpersonal violence is not on this list. But those core domains are repeated across CMS directives over and over again. So when you're focusing on domains of reference, these 4 are a place to start. The guidance also details 2 specific instruments, and Tim called them out: the Accountable Health Communities Health-Related Social Needs Screening Tool and Prepare. However, the guidance also notes that additional approval for gravity accepted instruments, it points to the regulation from the Medicare Advantage Special Needs Population Health Risk Assessment Guidance, long mouthful, right, as a reference. So if you're looking for additional accepted instruments, you can look here, is what the regulation says. And if you look there, it points directly back to gravity. So the Medicare Advantage Special Needs Population Health Assessment Guidance details that gravity is a good source for accepted screening instruments for the domains. This can be very helpful because if you're not doing AHC or prepare in your entity and your screening questions and answers are in the gravity accepted list, you're still generally in compliance according to the CMS guidance. And again, I think Tim's going to correct me if I'm wrong. So that's when addressing the reference domains by CMS guidance, accepted questions within gravity domain value sets are apply. Next slide. All right. So, gravity accepted instruments for the 4 domains include questions from comprehensive instruments, and this is important, and that assess multiple domains. And so you could do a one and done, like the AHC health related social needs instrument that contains all of the domains of reference. There's also Prepare, which does this as well. The AAFP Everyone tools and Health Leads, again, all of these have questions of reference for those core domains. I do want to make a note that not every single question from a comprehensive instrument is accepted. So it's really important to note that just because an instrument has some questions approved, not all will be. But also, and very importantly, because of the flexibility of implementation, gravity accepted instruments also include single domain instruments, such as the Hunger Vital Sign or Housing Instability Vital Sign, the Transportation Barriers Index, and Children's Health Watch Utility and Security Assessment. When you look at those comprehensive instruments, AHC, Everyone, and Health Leads, they are mostly just collations of the single domain instruments with a different name. So they take those core tiny components that are relevant and tested and validated for a single domain, group them under a major header, and call it a new thing. So if in your entity, if you are using the Hunger Vital Sign, and I have so many friends from my rural Vermont FQHC on the call today. It's great to see you. We use the Hunger Vital Sign in practice. So technically speaking, we're in compliance because the Hunger Vital Sign is one of gravity's instruments. It's just the addition of those next 4 domains that we would have to address. Next slide. Why are the assessment screening instruments being discussed in the context of HCPCS when the instruments are coded in LOINC? So Corey's asking a question. I'm trying to see if I understand. So Tim is on the call. So what the social SDOH risk assessment activity is supposed to represent is the application of an evidence-based instrument to assess how social determinants of health might be affecting a clinical condition of concern, right? So it's actually not screening in this instance. We call them screening and gravity, right? In this instance, it's you have a patient in front of you, you're using an evidence-based standardized resource to assess social risks for that individual and getting compensated for it, right? So the HCPCS is for the labor of that assessment of how the social terms of health affect the person and the condition. And Tim, I hope we're doing good here.
It is that direct, making that direct connection between the social need and its impact on the health outcome, and updating the medical record and the diagnosis list to reflect that. All of that is what they're calling the assessment activity.
So currently, because there are no standards in the regulation for using LOINC terminology in that activity. So you can use the AHC HRSN, not encode it in LOINC at all, complete all the other elements for SDOH risk assessment and still drop the HCPCS code. What we're doing here is trying to show how you can do both, right? So you can do all the activity, put it on the problem list, do the assessment, and in the same instance, have it encoded in LOINC to meet other elements of quality, of like standards-based documentation, interoperability, and the global aim. I hope, and Mike, do you want to have, we have a lot of time for conversation at the end, but if you have ideas, remember CMS did not build this guidance with interoperability. We're having a conversation on how we can do it because that is what we do. Matt, do you have a question?
Yeah, I thought I heard a little bit of difference in what Sarah was saying and Tim, and I just wanted to make sure that I didn't mishear or draw it out, because Tim, what I heard you saying, and correct me if I'm wrong, was that in order to do that assessment billing code, it's you don't it's not just completing the assessment, it's making the referral and following up to see about the services delivered and any kind of changes. So it's the full ecosystem. Did I hear you wrong, Tim?
So you don't have to, to actually CMS went back and forth on this. They actually asked for input from the community on whether or not it's a requirement to build a social determinant of health risk assessment if that same practice had to have the capacity to address identified social needs. They ruled against that and said you don't have to have the capacity to address the social need to still get reimbursed for identifying the need. So this is really the activity of and again, this is the clinician, this is the licensed provider that's doing this benefit called social determinant of risk assessment. Screening can occur by community health workers and others, but that's billed under the CHI, the community health integration. But it's activity of completing the screen, using an evidence-based tool, documenting the result, updating the problem list, and then making the connection between the social need and the clinical outcome that is being impacted.
So just to draw it out, just to put a fine point on the difference, it's the difference between the use of the word assessment versus screening that points to which code you'd be using for billing. Is that right?
That is correct. When the clinician, the licensed clinician does it, and then all these other activities, updating the problem list, making the connection between the clinical outcome and the social need, then that is the assessment. And that assessment has to occur at the same time as another medical encounter. When a community health worker or other person does it outside of that, then it is a screen and it's reimbursed under community health integration.
Thank you so much for that clarification.
Tim rocks. Thank you, Tim. And then Corey and I are talking, and I'm just trying to elucidate as well, because this is actually, it's really important because there was an opportunity to integrate guidance, including guidance that integrated USCDI. That did not happen. We're making that up here, right? And this is why this webinar hopefully will be of use across, further implementations and further gatherings. There's a question that I want to elevate, which is, so if I use a non-standardized instrument to assess, then I don't meet the requirements to submit a HCPCS code for the labor of screening and the documentation of problems. So the only term I would take out there is screening again. This is not a screening activity, it's an assessment activity. But if you do not use an evidence standard-based assessment instrument, like tool to assess the patient, then you and document on the problem list, then you should not be dropping the HCPCS code according to the regulation. They very clearly state, and Tim, is that correct?
It is correct. I just want to point out that one is not a precursor for the other. So I don't have to bill for the social determinant of health risk assessment in order to bill for community health integration. But what has to happen to bill for community health integration, there has to be an identified social need that is having an impact on the health outcome. So if I use a non-standard instrument, identified the need and updated the problem list and made the connection to the clinical outcome, I can immediately start billing community health integration, even if I don't bill for the social determinant of health risk assessment.
I think maybe we should have a part 2, Tim, where we make like a flow chart.
Yes.
And Matt's like, I'm all over it. But okay, so I hope this is helpful. So Tom, I don't know if there's guidance on that. So the question is, does the assessment have to use the validated questions verbatim, or can there be minor changes to the language? I did not see that clarity in the guidance. We do note that in order to use the LOINC terminology, you have to be true to the question as tested and validated in Gravity. Tim, did you see guidance on the?
So the accountable health community tool, you can, in the guidance for the use of that tool, you can make modifications, you can make changes. So they've been very open to that. There's nothing that says that you have to use it scripted exactly like it is. But if you use the evidence-based tool as a basis for conducting, and again, it is really like an assessment. So it is a discussion, is that assessment process, not just asking the questions.
Oh, there's a really good one here. Okay, so this is maybe Josh, that's a very we're gonna have a half an hour for conversation, so I hope it's okay to hold that one for because I'm gonna burn through a few of these slides,
course.
and Josh, I want to come back to that very thoughtful statement and give it time. So I just wanted to keep on going. So we talked about how you have the base recommendation for the SDOH risk assessment, which is using an evidence-based instrument that covers those 4 domains, right? Food and security, housing, transportation, and utilities. You're then creating ideally IC10 CM statements, even though CMS says you don't have to, but you also, what they do ask you to do is put a problem statement on the problem list for any ensuing identified social risk. So I'm going to try to keep us going so we can fully understand how the gravity terminology applies, and then we'll have a half hour for conversation at the end. This is just an example of all of the questions and answers that are in gravity for a given domain. So this is the food insecurity value set, right? So you have the prepare example, you have the AHC example, and then you have this by pointing to the CMS special needs plan guidance, the gravity examples, and gravity curates these for you in spreadsheets, the amazing terminology experts that I have the honor of working with. These are all available on the SDOH, on the social risk assessment page on in our implementation section. So if I were trying to see if health leads qualified, I could find that. If I were a pediatric location, I wanted to see whether the seek tool qualified, I could see that there too, right? So I wouldn't necessarily have to change my instrument in order to comply with the regulations, because gravity has a pretty big bucket. And Josh, I promise we'll get back. And next slide. And again, I think what Tim said is important. SDOH risk assessment is only one of the activities, and that's the one that specifies the evidence-based instrument. You do not have to draw, and that's the clinical one. That's the one that the social care entity is the least likely to utilize because it's a clinical activity, right? All of the activities of community health workers in community and social care settings and all the labor that they're doing is fully supported by that CHI term. Right. And that's where you don't have to necessarily use a specific instrument. It doesn't state that per se. It's in the clinical setting, according to clinical guidance, aligned with the quality measures coming down the pike that are in clinical settings and measuring clinical settings, that the standard is a little more specific. I just want to keep on going again. So if the ones we showed previously were just Loinc encoded. Again, Loinc encoded is a bar, but if you just want to know the instruments that gravity subject matter experts have assessed as valid for the domain, that it then would be eligible, even if they're not Loinc encoded, we have a implementation resource for that as well. Again, so you have the recommendation with AHC and prepare, you have the gravity Loinc encoded instruments, and you have all of gravity accepted instruments, all which are included in the guidance by domain by CMS pointing to the special needs plan guidance. Next slide. Whew. Correct. So Vanessa, yes and no, because you're talking about CHI here. I'm talking in general. We were just talking about the SDOH risk assessment concept. We're about to talk about CHI. So we were just talking about utilizing gravity instrument selection to support the SDOH risk assessment component in that HCPC code. It's PIN. We're not. I'm so sorry. We're not addressing PIN on this call. It's okay. We're talking the two HCPC codes we're leaning into because they're directly related to social determinants of health are the SDOH risk assessment term. And the primary outcome of what we just said was there's other instruments you can use. Gravity shows you options. And then we'll also be talking about CHI, and there's other documentation you can use, and gravity will show you options. And Mike, you're right, and some of the implementation confusion, that's why I think we need to keep on talking about it. So guidance on social risk documentation. This is important because, as mentioned in the SDOH risk assessment, you can't just stop at the application of the assessment tool. You have to document the ensuing social risks. So how do you document the ensuing social risks? With ICD-10-CM and Z codes, with ICD-10-CM, Z codes, and SNOMED CT codes. Next slide. And Mike, maybe we can work together to create implementation guidance after this call, given our partnership with this is the kind of like why the partnership to align social care and gravity are such good friends, right? It's the marrying of concepts like these HCPCS terms and regulatory guidance like USCDI, and together we can probably create materials that are really helpful to the ecosystem. Go, Tim. This is like, okay, great. So I'm just giving an example of how ICD-10-CM terms and SNOMED CT terms can issue from the AHC health-related social needs instrument, because we have it. So you use an evidence-based instrument to assess the individual. You're a clinician. Again, this is a clinician activity. What do I do next? I need to get an ICD-10-CM term or a SNOMED CT term. All right, so we created a resource for that, and we're happy to show this to you. So this is this is the process. It's our best suggestions for ICD-10-CM and SNOMED CT. Again, they're best suggestions by the domain. So even if you're not using the AHC health-related social needs instrument, it can still be a really useful guidance. Next slide. We just wanted to note a principles conversation here. Social risks and social needs based on any assessment instrument need to be verified by a care team member via personal interaction with the individual being screened or assessed. In this instance, this is grounded because this is directly applied to the person in front of the clinician and documented with them. So we know we've met that criteria. So, and risks inherent in the documentation of social risks and needs data should be understood by all parties collecting, documenting, and sharing such data, right? And this is all contained in our data principles. I also want to note the complexity of what we're talking about is these just came out in January. I think we're doing a really good job talking about new HCPCS that address a really important and complex thing. Next slide. All right, so I'm going to buzz through these slides because they're on the Confluence in the implementation resources. They're in the slide deck. But this is the example of using the AHC instrument questions. If I were a clinician and I wondered whether my patient's uncontrolled diabetes was affected and driven by unidentified social risks, I could, according to SDOH risk assessment, pull forward my AHC HRSN, use it to have a directed assessment of that patient, identify any ensuing positive ICD-10-CM term, document it in my visit, and put the problem list, the statement in that SNOMED CT on the problem. So that was just me in the use case of the SDOH risk assessment, right? I'm wondering whether there's SDOH drivers driving the condition that I see, using my instrument, documenting the findings, putting it on the problem list, and then that creates the ping for me to support my social care friends in CHI. I hope that was a helpful identification, right? So you have your question, your ICD-10-CM term, and your SNOMED CT term. For everything on this, there's a general unspecified concept, which is the unspecified, and then we also drill down into more specifics. Again, for the sake of time, I'm going to burn through a little bit so we can have the open conversation, because a lot of people on the call know this instrument and it is available on the Confluence. Next slide. You can see it addresses homelessness as well. So it was housing instability at the top, then homelessness, and next slide. And then you also can see inadequate housing here. Next slide. And then food insecurity is on the instrument as well. I just want to acknowledge that the AHC HRSN was a collaboration with the American Medical Association and our friends at AHIMA and AHA and longtime colleagues across the ecosystem. And it was given at the guidance of the request of CMMI to help them understand how to document ensuing gravity terminology aligned with their instrument. Next slide. Okay, so now we're going to go into CHI, right? So we just talked about how gravity terminology and instrument selection can support SDOH risk assessment. We're now going to transition to CHI. So what Tim was saying was, like, let's say I used my ad hoc instrument and I identified a social need, or I didn't use an instrument and I just talked to my patient and I found out that they had food insecurity. The identification of that concern is where I could ping and collaborate with my external social care expert entity and do collaborative care around that identified social risk and start utilizing that CHI reimbursement. Again, those core activities of CHI, there's the HCPCS term to support the reimbursement, and Gravity has a host of discrete terminology to support the documentation of care planning and individual interventions that all align with the activities in the CHI set. Next slide. All right. So on the this is the resource we have on the Gravity implementation webpage. So in addition to Tim's brilliant detailing, there is the Medicare Learning Network booklet, Health Equity Services in the 2024 Physician Fee Schedule Finder Rule document. We put that up there. And so it's just a helpful guidance after the presentation. And we just wanted to note that the AHC HRSN resource can be a general assist for documenting those IC10 CMZ codes and SNOMED CT terms. It's really important to note that according to the guidance, you have to document those unmet social needs that CHI services are driving in the medical record, right? So again, those diagnostic terms, how do I do it? Gravity has resources to support you there. Next slide. So as we go into talking about Gravity intervention terminology, it's important to understand how Gravity created all of its intervention terms. We have something called an intervention framework, right? And it's identified and defined activities of adjustment, assistance, coordination, counseling, education, evaluation of eligibility, assessment, and then provision, which is direct offering of a resource, and referral. So I hope some of these concepts sound familiar when you think about the CHI activities that Tim talked about earlier. Next slide. All right, so the CHI services list, I just brought it back up again. So we have that person-centered assessment, coordination of care, tailored support, health education, behavior change. We brought these back here because you're going to see them repeated across Gravity terminology in the next slides. Next slide. So when we built SNOMED CT terms, we leveraged those intervention framework and wrap the intervention types around key social risk domains, programs, and roles. I'm just going to note, in the nature of honoring social care expertise, every entity that is incredibly expert in assessing social risks in community and social care, we tried to build a refer to them bucket, right? Like, I identified something, please further assess and help me. And this is where those CHI terms can come in again. So you're identifying something in a clinical setting, a community setting, in collaboration with that clinical provider can be applying their expertise in social care settings, in community, and yet they can be getting reimbursed for that services if they're working and feeding back that information to the provider of reference, right? So in some sense, especially if we're talking about medicalization, it's also talking about supporting social care entities and CBOs and service delivery. And this is just a pathway for that. Next slide. Gravity also authors coordination terms for social risk, including general social risk terms like coordination of care plan, or coordination of care team, or coordination of resources to address social needs. So if I don't want to specify, and again, thinking about how coordination was part of that CHI concept, these are general concepts that can be used. Next slide. We also build specific terms. So coordination of resources to address food insecurity. That should look very, very similar to some of the core concepts in CHI. Or coordination of resources to address housing instability. So each of our social domains of reference have a coordination of resources to address blank term, which again can be helpful for discrete documentation of the activities that are happening in the ecosystem and how they're measurable and can be tracked for understanding how to further support and improve care delivery. Next slide. We also author terms for assessment and care planning activities. Evelyn was talking about this earlier. So every single one of our social risks has key terms to describe the labor of care planning and the work that is done there. So we saw that assessment was what, again, if you're not using the SDOH risk assessment pathway and the person doing that assessment is a community health worker in a social care setting, that assessment activity within CHI, you can document the CHI HCPC. You also can document discrete and measurable elements within these activities that are aligned with SNOMED CT and gravity terminology. So assessment for food insecurity, assessment of barriers in food insecurity care plan, counseling for readiness, counseling for food insecurity care plan participation barriers. All of these activities should feel familiar to some of the activities in that CHI concept. Next slide. Oh my Lord, I think we burned up through a lot of time. So the gravity, I think we're almost at time. So gravity nesting of interventions, this is just to show you that we have general coordination terms, domain specific coordination terms, and then all of these other subterms available in our gravity work, which are program based. If you're helping connect someone to SNAP or transportation or housing, connecting them going through either a housing voucher application process, all of those concepts and programs are in gravity terminology as well. Next slide. And then this is just a final landing. So if I'm thinking about how CHI concepts map to gravity concepts, we have the CHI concept, the gravity concept in general, and then example terms for food insecurity. And I am so sorry, I didn't realize we were closing it on time. I said we'd have a half an hour. And even if I race through these slides, we're very close to time. So again, so you have we had the CHI general assessments, and that's where that HCPC code is applied conceptually. And then you can see how gravity terminology that's aligned with USCDI can support more discrete documentation. Next slide. And then the last thing we wanted to mention before I moved on was we do have goal terms as well, specific aims and desired for states. We talked about that on the food insecurity slide. I do want to get to some time for conversation though. Next slide. And I think we're good. You can find everything we just mentioned on the gravity terminology value sets. And now I definitely want to make sure we have a little bit of time for conversation. And I'm so sorry it took so long. We were talking as we went on it. So I fear, but I hope we did a good job. So there's a lot of conversation in the chat. I do see a question from Corey Smith. I seem like there are cases when there are gravity assessment terms that might fall under the CHI assessment or screening definition. Is this correct? And it is yes, right? So I want to echo what Tim was saying earlier. If a clinical provider in a clinical setting is doing the assessment, that's a good time to drop that. That is the appropriate time to drop that SDOH risk assessment code. If a community provider is assessing in their holistic assessment way that we know our social care entities have told us that they do, the assessment terms that are available in Gravity can definitely support that CHI documentation there. And Tim, any further thoughts there? And again, my apologies for having us go to time. Well, Mike, do you want to come off to talk about the medicalization, or Tim, do you have any thoughts?
I was just going to say, that's probably one of the #1 requests that I'm receiving is assistance with having standard documentation, because people want to follow the rules and they want some guidance. So to the extent we can work together to provide structured ways to document, it would be rapidly adopted, I'm sure.
We do not have a ton of time, and I'm sorry, but I do want to get to some of the really beautiful and complex and important thoughts that are happening in the chat.
I mean, I think some of the comments around medicalization, I think this is an opportunity for us to define the role of community and have it separate and distinct so it isn't medicalized. But if we don't jump out front with the guidance and recommendations on how this complex array of benefits can be implemented, then there is a risk of medicalization. So I mean, I think to the extent we have, all the volunteers with Gravity and others, we can jump into this, then we can protect community and have it not be medicalized.
So I hear some questions. Thank you so much. I hear some questions. So Mike, do you want to talk about simplify some of these findings? Like, is there anything we can elevate from the chat? It sounds like people are agreeing with you.
Yeah, I think that the trouble here that we've seen is even trying to model a simple situation like
screening in hospital leading to referral for care transition support after discharge that will be community health integration codes. It's really hard to get all of the actors in the sequence of rebuilding coding structures, figuring out how to do documentation, how to translate the words used on the medical side to the words used on the community side. This is a beautiful canvas, I think, that we've created here that links those terms and the process in theory. The implementation winds up being really hard because the workflows are complex, and only some of them, I think, can be easily modeled because there's such a wide variety of circumstances, shortcuts, and a lot of community action that is really under the hood and does not need to be modeled on the medical side. And so trying to figure out where that boundary point is a lot of work. So what I mentioned to Corey, I think in one of the asides during the chat here is this might be a follow-up to some of the work that the co-design team came up with, because we saw lots of different circles on the expanded process list of things that have to happen for this work to work. And maybe trying to figure out how to tackle an implementation guide for something like this, 1 or 2 clinical scenarios will be common, will be a valuable exercise. We're trying to do this somewhat in some direct trust work. The problem is just that even describing the scenarios gets to be really complicated. So it's worth digging into. I'm just not sure the best way to dig into it right now.
One thing I want to state is depending on the drivers, the simplest thing to do is just drop a HCPCS code and get reimbursed. So the complexity that's represented and the capacity for these standards is something that can happen. Again, by regulation, it doesn't have to happen.
Yeah.
So I would never want the possibility for the granularity of all the terminology that we just expressed to be understood as an expectation, when the original intent was simply to ensure that the relationships between clinical partners and social care partners enabled the correct support and reimbursement of social care partners who were expert in what they do. Right? So
Exactly so.
the
Exactly.
heart
Yeah.
of the CHI term
Yeah.
is to center resources where the work is happening outside of clinical spaces.
One of the blocking points in our conversations, at least in Michigan, has been that the health systems want all the data. They want all that granular data.
Yeah.
And so if you're trying to make minimal connecting points work so that you can support the work of the community side, the health systems still want to harvest all of that data and all of those codes. And so
Correct.
trying to figure out the proper cleavage point for that work, I think is going to take some time.
And I know I skipped over it, but that's partly why that nesting slide is important to me. Like if you're just trying to do the lightest thing and talk about what you did, there is a very light touch coordination of resources to address food insecurity option, right? The lightest touch, not the referral to every specific program, not this, that, and the other thing. So we do want to make sure that as we can think about glide paths to implementing the terminology as well that meets people where they are. Matt? We're almost at time, and I think maybe we can go to the next step slide, but keep talking.
Yeah, sorry. Timothy, do you have any guidance on how technology is allowed to be used or not allowed to be used for these assessments or screenings? For example, can a patient-facing application that is, being employed by a CBO or a clinical provider conduct an assessment, or does there need to be human kind of making these things happen?
No, so I have sites right now where they're doing just that. They have in a waiting room, this particular site, they have the accountable health community tool on a tablet. Persons check in, they input their responses. But that is just the initial part of the assessment.
Mm.
The second part is the provider reviewing their responses, identifying the needs, updating the problem list, making a connection between their health outcome and the social need. Once that's done, then they can build for the social determinant of health risk assessment. But yes, they can leverage technology all day, but it cannot be technology alone.
We are at time. I'm sensing probably there might need to be a redux here where we come back and talk about an implementation. I want to thank all of you for this lovely, and again, I want to thank Tim and our friends at the Partnership to Align Social Care. Please join us. And remember, there's going to be a new Zoom link coming in the follow-up email. We want to know about this topic, whether it was helpful to you and ideas about future topics. So please let us know. Everything's available on the Confluence, every resource we talked about. I'm really, really glad, again, thank you, Tim, for coming. We knew that the integration of these HCPC codes and ground terminology would be an important topic. It certainly was, and we hope you all enjoyed it. And we hope to see you next month. And again, thanks for being out there.
Thank you.
Thank you.
Bye.
Sarah, this was great. Thank you.